So my name is Jason Taylor. I lead the commercial efforts for a company called Neteera. We're based out of Israel, and we are in the remote patient monitoring space. So we're going to shift gears dramatically from some of the more technical topics that we've been talking about. Before we get into kind of Neteera and how we're changing the space, I want to set the stage for why we're doing this and talk a little bit about the market that we're trying to serve and what is behind what's happening in patient monitoring. So this will be a US perspective, but a lot of it translates well into other geographies with some small variances. We are in, as everybody has talked about, a situation where the population is going to bubble, and aging is something that we can't escape in terms of the patients that we need to serve. In 2029 to 2030, it is estimated in the United States, 30 million people will be receiving care of some level in their home that they would otherwise receive in some kind of facility. That's 8 or 9% of the population. That is a massive amount of care that needs to deliver. If you think about how that's going to happen, we have an aging population. When I talk about this with people, we very quickly, each one of us can identify somebody in our lives that we're navigating through this or we're dealing with in this kind of situation. People are getting older. They're at home. They want to stay home. And so a couple of things are happening. We've got the aging population. They have chronic conditions. Those chronic conditions are expanding, and we have 1, 2, 3 per patient. We have an aging in place, I want to stay home as long as possible mentality. We also have a force of supply restriction. There are not enough beds to make different choices. And so what ends up happening is the acuity, the sickness of these people in the home environments is inflating as we go. So over the next few years, those 30 million people are not just going to be, these are old people who might be in assisted living, and we need to have home care aides. They're going to require more acute levels of care. So the other force that's acting on this is, and this is a United States number, in 2030, it's projected we will be short 1.4 million nurses from what is needed using today's ratios to serve that patient population. We're also going to be short about 320,000 doctors by the time we get to that point. And that's if we keep the current trend, and avoid some of the doctors kind of accelerating trying to leave practice for a number of different reasons. So think about those market forces for a moment. Get a lot more people at home. I have fewer people to deal with sicker patients, and at the same time, the ratio of patients per provider is going in the wrong direction, right? In a way that we cannot fix. We might be able to mitigate some of those numbers. We cannot fix that. Right? So that's the world we're living in. Care is moving away from the provider, right? And you have to do more with less, and that's just the reality of where we're going to be. The second thing, and this kind of pertains to the audience of kind of what we're all here to learn, we get stuck on labels of solutions. We're not always looking forward. So when I tell you people are going to be cared for in the home, a couple things probably pop into your mind. The first is this remote patient monitoring. When I say that, people think about I put a watch or a wristband on, or I've got some kind of medallion if I'm sophisticated, and I have a wearable device and it's transmitting data, or it's collecting and transmitting at night. Those kind of things, because that's how I monitor people in the home. And maybe I pair that up with telehealth, right? So I'm using One Medical or something like that, as opposed to going in to see urgent care or my primary, right? We think about that. The other end of the spectrum, I'm telling you, hospitals are out of beds, right? So you think about hospital at home. A hospital at home is gear. It's a lot of equipment, right? A true hospital at home implementation is unwieldy for most of what happens. So this is a full suite, all the telemetry, cameras, the hospital bed, et cetera, in your house to keep you from having to move your entire life into a high acuity facility. Right? Those are where we anchor the way we think about these things. Right? And so we don't think about them from a tech readiness perspective, because hospital at home is basically a hospital suite in a different building, and we have that infrastructure in place, and it doesn't scale. Remote monitoring, we kind of shove over here, right? It's this wearable, collectible, type of solution, and I'm going to tell you the secret sauce of the data behind this. wearable remote monitoring technology only works for healthy people. Sick people have no interest in being monitored by a wearable device. Okay, the numbers back this up. It's people who want their VO2 max for no reason whatsoever other than to compare with their friends, and maybe try and shave 10 seconds off some run they're going to do later. Right? Anybody who is older who is instructed to wear the watch or wear the wristband, it has a half-life of 1 charge. They don't plug it in, and when they plug it in, they don't put it back on. Now, patient adherence to monitoring is a huge problem. So I bring you those two things because where we need to go and how patient monitoring needs to evolve, not is evolving, needs to evolve, is to fill in that middle space, to fill in people who need multiple chronic condition management, to fill in people who might be at above an assisted living but in a sniff type of mode, but they are remote to the doctor. Right? To fill in people who are not beside their doctor, but they need more consistent monitoring. So we're going to use what we do at Neteera, if this is the right button. Which one do I don't know if we're connecting properly. As an illustration of the kind of thing that we need as we move forward in the healthcare industry. So this is our gear, right? And what you can see is a contactless sensor positioned in the room of somebody, in this case, somebody who's not very ambulatory, right, but is clearly in either a long-term care or a home facility. A sensor that is monitoring vitals for the patient. Okay, the reason we do this, we think of ourselves as extended peripheral view. Okay, you don't have enough nurses to keep track of everybody and how they're doing. I can give you a view of how everybody's doing. Okay, and I can do that not because I don't need a nurse, but because I need to be able to tell my nurses which patients require care more urgently than the others and maybe prioritize. So I do that. I pull in some sensor information. I'm happy to talk after about how all this works and why our sensors are better than other sensors, et cetera. We pull in all this information into the cloud. And then we run algorithms against everything we're collecting, and we start producing vital signs. FDA cleared, so this technology exists. It's a contactless way to monitor vitals. So I can do things like heart rate. I can do patterns of heart rate. I can tell if you got out of bed because I'm using radar, so if you're moving, I get to sense that. I can do things with your respiration around your inhale, exhale, your respiratory rate. I can tell how well you're sleeping and do some very cool things. These are providing pieces of data that then help a provider in their interactions with the patient. And it doesn't really matter if I am a doctor that I'm going to see you once a month in any event, and this data is just helpful during that meeting, right? Or if I'm in a sniff-like setting or a more accountable type of where I need day-to-day to monitor the patients, I can use that information and the trending analysis to see if there's something I need to do. Or I can use it in that high acuity hospital home setting to at least sense that other things need to take over. Okay? These are all real world cases. We have them deployed with customers that are happening in remote settings right now. So why do we do that? Because we can collect a tremendous amount of information. So our particular technology, it starts out with these vital counts, right? So, and all of these, as I said, FDA Class 2 device cleared, so these are real clinical outcomes. I've got heart rates and patterns. I've got things like your respiratory characteristics. Side note, there are some very, very smart researchers at a couple of very big name hospitals that you would recognize who believe that respiration is actually a leading indicator of a lot of other vitals and what it can deliver to you. So I can tell from your respiratory pattern when you're going to spike a fever before you spike a fever. It's considered the most important of all the vitals. But I can also tell if you get out of bed. I can tell if you're moving a lot or not enough. Maybe you're at risk for a pressure ulcer. I can tell how you slept. That could be useful to your provider, whether you're in a chronic management or whether you're in some kind of recovery from an ortho situation. But then I can start turning this into insights and analysis. Okay? And then eventually, I can start diagnosing some things in future. Now, in Europe, for example, we are already cleared to diagnose sleep apnea with this one remote sensor. By the way, just for scale, this is it. Okay? Little tiny unobtrusive device, sits on the wall. We actually have them embedded in chairs. in a couple facilities in the ER waiting room, so you don't even know your vitals are being taken, but they are, so you don't die waiting for care, because apparently that's bad. That's happened. People don't like it. We have a submission coming soon to diagnose for arrhythmia. As I said, I can do sleep apnea in Europe. It's not cleared here by the FDA yet, but it is CE cleared. And all of this information then helps support that care. Why am I doing it? Because I don't have enough nurses. I'm not trying to replace your nurse. I'm trying to give them a head start as they walk in the room to say, here's what's going on. Here's where you need to put your focus. Right? Here are the patients who require your attendance, more urgently than others. So if it's at home, it could be supportive information, around your next visit to your doctor. If it's in a facility or in a more accountable monitoring situation, I can change the pattern. Right? I can actually have your home nurse visit moved up because of something I'm seeing. And we have a study, it's not on any of these slides. We did a retrospective study. We can predict 5 days in advance whether somebody is going to get readmitted to the hospital based on their vital trending. Okay? That's just the commercial about us, but what we're talking about is what happens to the providing facilities and how do we need to get ready for things like this. Whether it's a Neteera device or somebody else's device, this is the future of how care is going to need to be delivered. Okay? More technology supporting human efforts because we don't have enough humans. Right? There's a right way, wrong way to do it. That's kind of moot. In our case, we have the contactless detection. We then have this tremendous amount of data that gets created. I'm taking vitals once per second and logging them in my system. Okay? Right now, at a very small scale, a couple years in, we have 40,000 patients being monitored by our devices. Most of them in the US. We're in 19 countries, but most of the other 18 are small pilots. I've got data per second on 40,000 patients. Okay? I need all of that data to be able to generate the insights we generate, and you need all of that data in the facilities to generate your own insights and to merge with other information. And we do that to try and affect the way we deliver care, both in a positive sense and a negative sense. Right? You don't want to be in the room of somebody who's doing very well while there's somebody decompensating in the room next door. And all that, obviously, for improved outcomes. So, what does this mean? It means, in the end, what I really need to think about in the delivery of healthcare is I've got an unbelievable amount of data coming in. I've got an opportunity statement of merging that data with other data that I have, right, coming out of my own legacy systems, such as kind of EHR feeding into my analytics and back. Could be ours, doesn't matter. Could be in your own. And I can start combining things into really advanced combinatorics. So I can monitor somebody and say, here are the respiratory patterns. If you know they have COPD, you can merge that in and do analysis on that data set to say, here's what I expect out of a COPD in this phase for my patient. Here's how I can better plan the care and manage this patient. Because the goal is keep them where they are. All these other factors aside, there's also a study that has been done that says recovery or longevity increases if you are in your own home surrounded by your own support team. You heal better at home. We have a pilot going on with a very prominent research firm that's starting next month where they're going to send oncology patients doing bone marrow therapy home in between infusions because they believe they recover from that therapeutic injection faster in their own house as opposed to sitting a few days in the hospital and waiting for the next treatment. And we're going to monitor them, as they go so that they're still under the eye of their clinician. The reason all of this becomes super important is because it creates a huge need on the IT and systems of the providing companies, whether that's a hospital system or a home care agency or some kind of in-the-middle medical group that's providing services for assisted living or SNFs or anything like that. And we come up with a need situation that says, we need to have a plan for data organization that we've never had before. Okay? And I come from the higher acuity sense. Epic is kind of the world that my frame of reference comes from. This is beyond being able to look at the data warehouse. Okay? This is, I need timely clinical information to make sure I've got a complete longitudinal picture to be able to get the most value out of this kind of data. Okay? Because if I know the conditions, if I know the medications, if I know the events, both acute and subacute in terms of episodes that happen, I can use all of this data to better predict the patient path and the patient outcome and then the care that's going to be delivered by it. Okay? So there's this huge opportunity, but I need to get my data in a place that it can be organized. Okay? That's not default true in any EHR there is, kind of in the world right now. Okay? Oracle Health promises some stuff. I don't know what that new one's going to look like. But the existing ones are just not designed for that. So we need to do that independently and mirroring those clinical systems. The second thing that we need is unbelievably good data orchestration. Okay? This is, as I said, per patient, 1 data point per second. I don't know if I need to store all that, but if you start doing table joins on all the things we know about our patients, you get to billions of records really, really fast. You cannot store those in multiple locations and keep any kind of integrity, any kind of security parameters. There's no realism to saying I'm just going to make a data warehouse copy of my EHR main file. Okay? So we need to be able to access sources of truth, know where they are, get the data out when we need it to the person that needs it in the moment they need it, right? And present it in the right way. We can do some of that, but that's really going to fall to the care delivering organization. Right? So all of this to say, when we start architecting, we need to think about the fact that there will be more systems providing more insights, using AI to generate some of those insights, needing access to data sets that can be machine learned and mined for outcome, right? Available for analytics, not OLTP, which is typically what we see in the EHRs. We need them to be OLAP-oriented databases. And we need to be able to perform at a level that we can drive out those kind of insights. Okay? And then, as I said, and this, our hosts do a wonderful job of this at InterSystems, you need a strategy for orchestrating and transforming data. And you need to be able to do it real time, from any system to any system, to drive that clinical result, because you will have nurses that are dependent on this information in service of these patients. And there really is no getting around that. So I will leave you with a quote. We do a lot of work with Guthrie Clinic. So if you're familiar with Guthrie at all, in Pennsylvania, Terry Couts, recently, she just left and went over to Sharp down in San Diego. But Terry is the chief digital officer. Allowing us to be more proactive in the way we care for our patients has been huge, both in terms of outcomes, but also in terms of managing our workforce and how we care for the patients. We are not reactionary sick care people in these moments. We're able to actually look at the trending analysis of the patients that we're watching. Right? And they have a number of these devices deployed for over a year and are seeing substantial results in terms of proactive care. And they even, although I don't have stats that I'm allowed to present, but anecdotally, they have some proven prevented readmissions from watching and predicting this. And it's allowing them to overcome the fact that there are not a lot of nurses who are putting up their hand and saying, I really, really, really want to move to rural Pennsylvania.
I just want to take a photo with later, but I want to add a question. So what happens with the patient? Because to me, it's designed for the patients that are bedridden at home. Normally, you would move around. And then you want to have that 1 second.
Yeah, that's true. So our solution is for a non-ambulatory moment. It doesn't necessarily mean that it's only non-ambulatory patients. We have scenarios in the home care that we're playing with. Home care is evolving in all senses. I mentioned we embed our devices in furniture. So in our new home care program, we have a device that's on the bed, and we have a device sitting in their recliner in the back, invisible to them. And we can combine those into one set of readings. We don't have the ability to monitor a patient as they move around their house. Safe harbor, give me 18 months, and I've got an 8-antenna radar system that can track 4 independent people as they move around a room and tell them apart from each other. Yes. Yes.
Say the next session's waiting, but a round of applause, please.
Thank you.